is a consultant clinical psychologist, author of Users and Abusers of Psychiatry and a Straight Talking Guide to Psychiatric Diagnosis. Also co-editor of Formulation in Psychology and Psychotherapy. She is the former programme director of the Bristol Clinical Psychology Doctorate. She's worked in mental health, adult mental health settings for many years. And she was lead author along with Professor Mary Boyle for the Power Threat Meaning Framework. Lucy is an experienced conference speaker, lecturer, and currently works as an independent trainer. She can be found on Twitter at ClinPsychLucy. And obviously she's a key member of the A Disorder for Everyone team. Massive welcome to Lucy.
Great to be here, and lovely to see everyone, or hear from everyone in the chat room. And thank you, John. My main role in the AD4 events is to mess up the technology and get very anxious about the timings. So I'm delighted that we're 10 minutes ahead. That's good. As usual, I have a lot to say and not enough time to say it. So what I'm going to do is a presentation which, if you've been to the AD4E events, you will have heard in a slightly longer version. You can go off and make a cup of tea if you already heard this. It's the same old stuff, but it's important stuff. And it's kind of sets the scene for the AD4E events when we do them live. And it's also setting the scene for what we're going to hear about today. So the whole day is about challenging the culture of psychiatric diagnosis, and this is the world's briefest overview of critiques of diagnosis, if you like, just to set the scene. And everything I say will be picked up by other speakers throughout the day, particularly by James Davis and Paul Kaplan, who will address these kind of theoretical arguments very directly, but also by people telling their stories of what it has been like to receive a psychiatric diagnosis. So as usual, I have rather busy slides. You don't have to read everything on the slides. I will talk you through the important bits of the slides. So as Joe said, it's really, really important to emphasize that, of course, people's distress is very real. One of the more tiresome ways of attacking some of the things we say is to say you're denying people's emotional distress. Of course, we're not. These are very real, very awful and overwhelming experiences, but what we are questioning is the explanation. Are people really suffering from medical illnesses which need diagnosing, or do we actually need completely different ways of understanding distress? So in the next 25 minutes or so, I'm going to briefly look at critiques of diagnosis, and I'm just going to signpost you to the alternatives which other speakers will be talking about throughout the day. And as Joe says, I wrote this book a couple of years ago, A Straight Talking Introduction to Psychiatric Diagnosis. It's meant to be an accessible introduction to the arguments, because most of the things I'm going to say are not made clear, are not passed on to people who receive diagnoses, which, as Joe said in her introduction, are offered, imposed very often as though they are accepted facts. And it seems to us in AD4E that people actually have the right to get the full picture. So this book is a way of introducing you to the arguments. It's not a book about saying you cannot use this way to think about yourself and your difficulties, but it is a book about saying you need to have choices and you have the right to have choices and to be fully informed. So here's the key messages. Few people can afford to give up diagnosis entirely. So we live in a diagnostically based world. Of course, you're going to need to retain your diagnosis for some purposes, perhaps for access to services or benefits and so on. But do you have to feel you need to take this on as the way of understanding your difficulties as part of your identity? That's a very different question. So it is our view that if the authors of the diagnostic manuals are admitting that psychiatric diagnoses are not supported by evidence, no one should be forced to accept them. If many mental health workers are openly questioning diagnosis and saying we need a different and better system, then service users and carers should be allowed to do so too. Okay, so here is the tiny overview of critiques of diagnosis. As many of you will be aware, diagnoses are listed in what are sometimes called psychiatrist Bibles. There's two of them, but they're very, very similar. There's the DSM, drawn up in America, but applies worldwide, and there's ICD, drawn up by the World Health Organization, but also applies worldwide. They're very similar, and they identify about 300 plus different ways in which we can apparently be mentally disordered. Around 1900, there were thought to be about 3 ways in which we could be mentally disordered. So something interesting has happened since then, but these are ever expanding manuals. And some of you will be aware that the most recent edition of DSM, because these manuals are regularly revised about every 10 years or so, was an extremely controversial event. So this came out in 2013. And the reason I like to show these quotes is because these are not the opinions of people who might be kind of labeled, sometimes dismissed as mavericks or so-called anti-psychiatrists. These are actually statements by America's most senior establishment psychiatrists, particularly Dr. Alan Francis, who was the chair of the previous committee, the DSM-4 committee, who made the damning statement, there is no reason to believe that DSM-5 is safe or scientifically sound. It is, according to some of his colleagues, an absolute scientific nightmare. Patients deserve better. The weakness is its lack of validity. So this doesn't actually mean that these particular people are arguing for the end of diagnosis. They think there's a better system round the corner, and millions of dollars are being poured into trying to develop one, starting from scratch. So I think that's a waste of time and money, but they are convinced that this avenue is worth pursuing. But how many people are aware that the very foundations of psychiatric practice as we know it are so shaky? Well, some people know it because you see these headlines appearing. Don't need to read all these, but you can get the flavour that a number of people are noticing that Western psychiatry is in crisis. They are asking, is psychiatry dying? And psychiatrists, because this isn't a psychiatrist versus psychologist battle, many psychiatrists are equally unhappy. Psychiatrists like Dr. Tamimi, who has spoken at AD4E, are saying it's time to reach beyond diagnostic dependence. We've reached the end of this particular way of understanding people's distress. We need something fundamentally different, is what he and we are saying. So, just to look at this in a bit more detail, it is, I think, important to get a bit of a grasp of the kind of the theory underpinning psychiatric diagnosis and why it's so flawed, so that we can really understand the difficulties we're in, and from our point of view, how very much we need alternatives. So why do we need psychiatric diagnosis? So in theory, you need psychiatric diagnosis to indicate what treatment might be necessary, what outcome you can expect, what the cause might be, so that professionals can communicate with each other, so that we can research into these so-called conditions. And I would argue that psychiatric diagnosis actually performs all those functions fairly badly. If you've worked or been in psychiatric services, you will know that treatment consists of more or less whatever drug hasn't already been tried in a relatively random way. You will know that very little is known about the so-called biological causes, like the claims about chemical imbalances, which have never been backed by evidence, and so on. Nevertheless, that's in theory why you need diagnosis. But even more importantly than that, psychiatry claims to be a branch of medicine. Medicine is a branch of science. Any branch of science needs to be able to have a reliable and valid classification system at its foundation. That's true of physics, chemistry, biology, any branch of science. If, for example, you can't identify what an atom is and distinguish one kind of atom from another, then in chemistry, you will not be able to draw up the general laws about how atoms interact, which allow you to build up the body of knowledge, which we would call a body of science, in that case, chemistry. And in psychiatry, the equivalent is we need to be able to identify what illnesses we think we're dealing with. We need to be able to say we can confirm or disconfirm the presence of this so-called mental illness. We can distinguish it from that one. And if we haven't got that as our absolute starting point, everything else is up for question. It's impossible to overestimate the importance of that. The idea that the main professions involved are medics and nurses, mainly seeing people in hospitals and clinics, predominantly relying on various types of drugs, all of this would be up for question. As Peter Breggin, a psychiatrist himself, put it, without diagnosis, psychiatry would become something very hard to justify or defend, a medical specialty that does not treat medical illnesses. I think we can see that could be a little bit problematic. And more bluntly, Dr. Alan Francis has said there's no definition of a mental disorder. I mean, you just can't define it. It's bullshit. So I sometimes like to say, how many people at the point at which they were told you have bipolar disorder or a personality disorder or whatever are also told you realise that one of the most senior psychiatrists in the world, who was chair of the committee drawing up these diagnoses, has said that they are bullshit. Not many of us, I suspect. That's why we need AD4E. So to go into this in a little bit more detail, obviously in other branches of medicine, I might say legitimate branches of medicine, diagnosis is very important. And so it is useful, I think, to understand a little bit about what we mean by medical diagnosis. When you go to your GP, let's say you're feeling tired and thirsty and you're losing weight and feeling generally under the weather, you will be presenting with a pattern of symptoms which are largely subjective complaints. They're quite hard to verify from the outside. They're what you personally feel, and they could arise from many, many causes. There could be many reasons for feeling, let's say, tired and thirsty and losing weight and urinating more than usual and so on. But your doctor ideally is pretty skilled at recognizing these patterns and realizing there's one particular pattern or perhaps a few patterns that sometimes present in that way, and your doctor will then ideally be able to run some tests which show certain signs which will confirm or disconfirm that in this case perhaps this might be diabetes. And they would do that by looking at levels of sugar in your urine, which are there because your pancreas is not functioning as it should. So we can see at that point, the doctor is able to say, I'm afraid my guess, based on your symptoms, that this may be diabetes is right. We have run the tests. We have identified the sign that something is going wrong in the way your body is functioning. We can call this diabetes. And when researchers originally came up with that term, they then used it to further develop it and refine it and find out whether there are other symptoms that diabetes could have and so on. We gradually find out more about it. So that's not how it always works quite as simply as that in general medicine, but often it does. And in psychiatry, we're looking at something very, very, very different. Partly because, as I think you can see, almost everything that people come along to with experiencing problems with is at the symptom level. It's not true of a few things like dementia and so on, but generally people are coming along saying, I feel anxious, I feel panicky, I hear voices, I can't leave my house without feeling terrified or whatever. So we don't actually have the signs to check that out. If you tell your doctor you're feeling suicidal and desperate, they don't run a test of your serotonin levels, despite what you may be told about the role of serotonin in the condition we call depression. They simply say after a bit, well, this sounds like depression or whatever. So we don't have ways of checking out whether the symptoms are actually a sign of some kind of medical illness. We don't have the means of checking whether this is best seen as a medical illness at all. The only evidence you've got it is a doctor said you had it. The only evidence that perhaps they got it wrong is another doctor contradicted them. There's no objective way of checking it out. But even more importantly, the things we're calling symptoms, which is a very misleading word, are actually examples of unusual ways of thinking, feeling, and behaving. They're not examples of things that have gone wrong with your body, like rash and thirst and so on. So how do we make a decision about how the ways in which you ought to be thinking and feeling and behaving in a given situation or a given set of life circumstances? Well, I think it probably doesn't take us very long to work out that those are not actually medical judgments. How ought I to be thinking or feeling and behaving? They are social judgments based on social norms, based on the shared beliefs and standards of a given family or community or culture. And the interesting thing is that if you look at some of the criteria, in this case for so-called schizophrenia, you can see that these are social judgments. You don't need to read all this, but I will highlight some of the criteria. You might have bizarre delusions. Well, who decides what's bizarre? Involving phenomenon that the person's culture would regard as implausible. Well, what has culture got to do with it? These are meant to be medical judgments. You know, bodies are meant to operate more or less the same across the world. And if we go on, you may be experiencing marked social isolation. Well, is that a medical symptom? What are the reasons for that? We've all been through that with COVID. We've all suddenly developed the symptom of marked social isolation. It's not because we've all developed a mental illness. Markedly peculiar behaviour, what on earth is that? Hoarding food, talking to yourself in public. This was pre-mobile phones, of course. We all talk to ourselves in public nowadays. It's suddenly become a normal thing to do. Odd beliefs or magical thinking inconsistent with cultural norms. You get the point. These may be signs of someone who's struggling and needs some kind of help. They may not be. You can't tell unless you put the context in. Most, if not all of these thoughts, feelings and behaviours actually make sense in context. But if you simply look at a list like that, it looks quite daunting, but if you unpick it, you can see these are social, not medical judgments. They're signs of distress. There's no evidence that they are signs of a medical illness. And this is even more apparent in some of the more toxic diagnoses, borderline personality disorder, where you can see a whole list of ways of feeling and experiencing relationships that would make perfect sense if you added in the context which we know about, which is that many people given these labels, this particular label, not all, but many have experiences of abuse. It is not surprising in that case that people are scared of being overwhelmed or hurt again, that they may feel angry and distrustful. These experiences make sense in context. So how do we decide who is so-called mentally ill? We actually can't make a cut-off point. We don't have the medical tests that will give us the cut-off as we do in most physical illnesses. We are essentially applying personal subjective criteria based on social norms. And the chair of the DSM-5 committee actually admitted this. We've been waiting for biomarkers. By that he meant the evidence, the parallel, if you like, for the test for diabetes, which would be looking for levels of sugar in your urine, that would enable us to say we've discovered that these are medical illnesses and we know something about what causes them. We actually do not have that evidence. So here we are, psychiatric diagnoses are not what they claim to be. They're based on not on what goes wrong in people's brains or bodies. They're social, not medical judgments about unusual ways of thinking, feeling and behaving, which again is not to deny the distress that people certainly suffer from. But I think we can see there are huge implications for that, for the person who's been diagnosed, for us as a society, for psychiatry and related professions as and institutions, and for the whole political systems in which diagnosis has become to play a very important part. So we're left with these circular explanations. Why does this person have delusions? Because they have schizophrenia. How do you know they have schizophrenia? Because they have delusions. Any diagnosis operates in the same way, any psychiatric diagnosis. Why does this person have mood swings? Because they have bipolar disorder. How do you know they have bipolar disorder? Because they have mood swings. Why does this person feel so distrustful in relationships? Because they have personality disorder. How do you know they have personality disorder? Because they feel distrustful in relationships, and so on. There's no exit point, as there would be if you presented your GP, let's say, with a headache, which might or might not be a result of a number of things. But you could do a test to exit that circle. It sounds like an explanation, but it's not. But of course, even though it's not a valid explanation, it has devastating often and certainly very profound effects on the life of the person who is diagnosed, on their sense of themselves, on their sense of what needs to happen, and on their whole future life very often. And it's important to notice that, you know, at a very senior level, this way of thinking is being questioned. Here's a United Nations report. We've been sold a myth that the best solutions for addressing mental health challenges are medications and other biomedical interventions. and diagnoses are being expanded without a solid scientific basis. This is true of their recommendations. We need to look much more at social factors in people's lives. We need to abandon the predominant medical model that seeks to cure individuals by targeting disorders. Mental health policy should address the power imbalance rather than the chemical imbalance, which is a wonderful phrase, which again could serve as a slogan for all the AD4E events. It's about power imbalances, not chemical imbalances. Another slogan that could serve for all AD4E events is, instead of asking what's wrong with me, ask what's happened to me. And of course, people have a range of reactions to being diagnosed. It initially sometimes brings relief. I think this is partly based on the hope that often turns out to be false, that this will give me an explanation, give me a clear way forward, that I will soon be kind of recovered, whatever that means. Some people have mixed reactions, but some people find the imposition of a diagnosis as traumatic, if not more so, than the events that brought them into services in the first place. This is a very, very, very serious matter. We need to think very, very carefully as professionals about what we're doing in offering or imposing diagnoses on people who are already, almost by definition, struggling with their lives. Okay. It's also important to be aware that this is not just about what happens in the largely Western and Westernized cultures within which diagnosis was drawn up. There is a movement called the Global Mental Health Movement, which is exporting the diagnostic model across the globe in a way that is scandalous in my view. It's a kind of hidden scandal. Most people seem to think this is a good thing. Low and middle income countries don't have access to all wonderful Western treatments. Well, to be honest, they can well do without them. It hasn't worked in Westernized countries. It's even less likely to work in cultures with very different ways of understanding, healing and expressing distress, which research has shown often do so far more effectively. If you want the best chance to recover from something we might call psychosis, then you may be better off in a village in, let's say, in the middle of South America, well away from medical facilities, than you would be in entering a Western psychiatric hospital. And psychiatrists like Hume and Fernando have argued this is simply another form of colonialism. It's not about invading countries with tanks and soldiers, but it is about invading people's minds with a certain set of beliefs which they are persuaded to think that they want. And there's no evidence that that's going to be helpful. Quite a lot of evidence that it's going to be damaging. We are mainly able to provide non-Westernized cultures with examples of what not to do. Okay, and it doesn't have to be like this. It doesn't have to be like this. So you will be hearing from a number of people today who say their recovery was actually about escaping from this system. Their recovery started at the moment at which they began to reject the messages of diagnosis. And there are some very inspiring stories on MAD in America. You'll be hearing them here today. And the number of the people I've listed there are actually going to be speaking today. And part of what we hope AD4E can offer, and Jo's already given some examples of this in her introduction, is this opportunity to look at things differently, which people are routinely not offered, are actually actively discouraged from pursuing very often. Try disagreeing with your diagnosis, it often doesn't go down very well. People have a right to know about these alternatives and a right to decide for themselves what makes most sense for them. Okay, so this is just the briefest hint about what's to come from other speakers. There are a number of alternatives to the illness model. It's not like we don't have better ways of doing things. We do, many better ways. They tend to be things that you have to be lucky to come across. They're certainly not routinely offered. But very broadly speaking, the trauma-informed approach recognizes the mountain of evidence that people who come into mental health services or experience various forms of distress very often have adversities of all types in their backgrounds. There may be things that happen interpersonally, in their relationships. They may be things that have happened in their social circumstances. So I don't need to go in this in detail, and I won't, because this theme is going to be picked up by a number of other speakers, by Akima Thomas, by Gabor Mate, by Matt Ball, I suspect, by Indigo Day, I suspect, by Karen Traceman. And if you Google trauma-informed practice, you'll find there's lots out there. This is an absolute must-read book, by the way, Trauma and Recovery, and The Body Keeps the Score also, if you haven't come across them. But from this perspective, what we call symptoms are better understood as survival mechanisms. They are essential in the face of overwhelming events and circumstances, but they may have outlived their usefulness. And another slogan, we are dealing with people with problems, not patients with illnesses. A bit later in the day, I'm going to be talking about a particular way forward called the Power Threat Meaning Framework, which encompasses a number of other non-medical approaches and which is gaining attention across the UK and around the world, which I think shows very much how, how we are starting to recognise we need a very different approach. If you want to put it at its simplest, instead of diagnosis, we need to listen to people's stories. This is a quote from an excellent book, which is entirely written by people who survived the psychiatric system. Until we're able to use our own stories to tell our own words, to tell our own stories, the context in which we find ourselves, in this case, the psychiatric system, says our stories for us and usually gets it wrong. In the context of the medical model, the story we learn to say is that we are ill. We begin to see ourselves as ill. We tell stories of illness, and the psychiatric system, by extension society, accepts illness as a story of our distress. Being able to tell your own story, not the illness story, sets a new social context, one in which mad people are seen in a new light. In part, healing happens in the restoring of our lives. When he proclaimed, "You have an illness, mental illness," I responded, "I thought I had stories to tell." So we're going to hear many, many stories today. Final slide. Instead of asking what's wrong with you, we need to ask what's happened to you. Jackie Dillon, who's been a very key member of the AD4E events. Instead of diagnosing people, we need to listen to their stories. A simple but radical message in the context of the dominance of the biomedical model of emotional distress. Great, thank you for that.